Michael Barrett talks next with Dr. John Higgins, Assistant Professor of Medicine at the University of Texas School of Medicine, about the effects of altitude on the heart.
I'm Dr. Michael Barrett, and with me today is Dr. John Higgins. Dr. Higgins, welcome to ACCEL.
Thank you very much, Michael.
I understand you recently conducted an extensive review of the literature on the cardiovascular effects of altitude. Tell us about that.
Mike, we were finding that we were having patients coming in and asking us about traveling to Denver, for example, the Rocky Mountains, which can go up to about 14,000 feet. And also we had a couple of early retirees who were looking to climb Mount Kilimanjaro, which is the highest mountain in Africa, around about 5,900 meters or 19,000 feet. Some of them were quite healthy people, and others did have a history of cardiac disease. So we looked in the literature and we couldn't really find a good algorithm or a good approach to this, so we decided to review the literature.
And what did you find in terms of the major effects of elevated altitude on cardiovascular function?
The major effects were threefold. Firstly, there is an immediate decrease in oxygen delivery to the tissues, and so there must be a cardiac response to that. Secondly, there is an increase in pulmonary vascular constriction, which increases pulmonary afterload. And then thirdly, an increase in sympathetic nervous outflow with mainly an increase in epinephrine, but also norepinephrine. Just to go into a little bit more detail, the first effect is that going to altitude, immediately there is a decrease in oxygen in the air. This is oxygen poor air. And one of the heart's main functions is to deliver oxygen to the tissues. So in order to maintain that, there have to be some immediate changes in the cardiovascular system. The oxygen delivery to the tissues is the product of the cardiac output and the oxygen content of the arterial blood. So immediately on ascent to altitude, that oxygen content of arterial blood goes right down. In fact, just as a comparison, at sea level, our oxygen saturation of hemoglobin is around 98 to 100%. At around 14,000 feet or 4,300 meters at high altitude, that plummets down to 80%. So because of that immediate reduction in the arterial oxygen content, in order to maintain the oxygen delivery, the cardiac output must go up. And the major cardiac output is the product of heart rate and stroke volume. The major adjustment is an increase in the heart rate, about 10 to 30%. And by doing that, the cardiac output is kicked up, and that can compensate such that the oxygen delivery to the tissues is maintained. Now, we have to go back to physiology a little bit. In terms of the oxygen, the saturation of hemoglobin and the partial pressure of oxygen in the arteries, that oxygen-hemoglobin dissociation curve, which you can remember from your medical school days, there is a change early on in that curve as well. The body detects early on that all of a sudden there is less oxygen on the hemoglobin. And so it shifts that curve to the left and says, hey, we need more oxygen on the hemoglobin. So the hemoglobin actually binds oxygen more. But the downside to that is the tissues, which are trying to extract the hemoglobin, it's harder for them to get oxygen delivery. And so they, after a short period, increase the amount of the 2,3-DPG and shift the curve back to the right, and so that there is more oxygen delivery to the tissues. So there is a little bit of an effect on the oxygen and uptake and delivery early on as well. The second effect that I mentioned earlier on was the pulmonary vasoconstriction, and that results in up to about a 3 to 5-fold increase in the mean pulmonary artery pressure. And the idea with this is that basically the lungs realize that they're getting oxygen-poor air, and so they want to basically shunt the blood that is coming in to the really well-ventilated alveoli, so that there is more of a matching between the well-ventilated alveoli and the capillaries in the lungs. But the consequence is that the mean pulmonary artery pressure does increase. And then thirdly, the neurohormonal effects, as we talked about, there is an increase in the sympathetic and parasympathetic nervous system distribution, such that overall effect is an increase in the sympathetic balance on that system, mainly from an increase in epinephrine. And so that can have an effect both on heart rate and inotropic and chronotropy.
And what do these cardiovascular effects mean for our patients with coronary artery disease?
Well, with coronary artery disease, because of the increased heart rate earlier on to try to compensate such that we can deliver the same amount of oxygen to the tissues, these patients tend to get symptoms a little bit earlier. In fact, they may have quite stable angina at sea level, and then they go to high altitude, and all of a sudden they're a little bit tachycardic relative to themselves. So they may have symptoms which they didn't have, and or their symptom onset may be earlier with the same amount of exercise, because for the same amount of exercise at altitude, their heart rate and hence their cardiac output and oxygen consumption is going to be higher for that exact amount of exercise at sea level. So the main thing that we like to tell these patients is be aware of this and to take precautions as they would at sea level, but be wary that their symptoms, they might notice them a little bit more frequently and earlier than at sea level.
And what about our patients with heart failure? Will they have a similar change in their symptoms?
Well, the main thing with heart failure, Mike, is that because, again, of the reduced oxygen, they're probably notice their dyspnea is going to come on a little bit earlier with a lesser amount of exercise or activity than at sea level. And also, if they are a tenuous heart failure patient that is quite sensitive to increased right ventricular afterload, they may notice that they're getting symptoms quite a lot more. So it's important to tell these patients about these facts and that they should really take it slow when first at altitude.
For patients with arrhythmias, are they at risk of more lethal arrhythmias, basically?
Certainly they will become more tachycardic, and patients, for example, who have atrial fibrillation or flutter that we're rate controlling, their rate will definitely go up, and that's mainly, again, from this increased epinephrine and sympathetic activity. You may want to consider, if you have a patient who's going to altitude, to potentially up-titrate their beta blockers, or if they're a highly motivated patient, you can give them some specific instructions about increasing the dose of their beta blockers depending on what their heart rate is. In terms of the lethal arrhythmias, there have been a number of studies where patients, including some cardiologists, wore Holter monitors and they went to altitude, and most of the time they did notice there was an increase in PVCs and short runs, but none of the studies really showed any increase in clinically significant ventricular arrhythmias. For example, there was no increase in sustained ventricular tachycardia, but there is certainly a theoretical risk. It would be important to talk to these patients and tell them that if they did notice that they were having more symptoms, that they probably should descend from that altitude and or decrease their activity level.
And what about our patients with adult congenital heart disease who go to high altitude? What are they at risk for?
The main things that they're at risk for, Mike, relate to this increase in the right ventricular afterload. So, for example, in these cases, if they do have some shunting in the heart, with the increase all of a sudden in the pulmonary pressures, they may actually get more shunting from the right to left, and of course more symptoms, as well as a lower saturation in their oxygen. So certainly they need to be aware of that. The studies that have been done have noticed that these effects are mainly occurring at what we call high altitude, which is over 2,500 meters or over 8,000 feet. In the low or moderate altitude, these people don't seem to run into as many problems. One of the questions that we do get quite a lot is, we have a patient who has severe pulmonary hypertension or Wenger syndrome, and they want to know whether they actually can go on an airplane. And as long as that airplane is adequately pressurized, it is safe for them to go on the airplane.
This phenomenon of high-altitude pulmonary edema, tell us about that.
Basically, it does seem to have a genetic predisposition and typically occurs within the first 3 or 4 days of arriving to high altitude. And it's actually a very complex multifactorial pathophysiology which relates to both increased intravascular pulmonary vasoconstriction and pulmonary vascular endothelial cell dysfunction. And these people will rapidly go into pulmonary edema. So this will be a full-blown episode of pulmonary edema where they're class 4 heart failure, and they need to be treated immediately. And what we recommend for this is to have these patients obviously stop, immediately descend supplemental oxygen to maintain their saturation over 90%. Because of the pulmonary edema, they're going to have real problems with their alveoli oxygenating their capillaries. And as well, we do have some treatment with medications, including nifedipine, as well as having them perform no activity.
Based on your review, what do you think cardiologists need to advise their patients who are planning to travel to high altitudes?
I'm dividing this up into patients, firstly, who don't have any cardiovascular disease. So that's your healthy patient that you're seeing, and they come in and they say they want to go climb Mount Kilimanjaro. So we firstly recommend if they're not already doing it, prior to going to altitude, it's a good idea for them to get into some sort of regular exercise program. For example, 3 to 5 days per week of aerobic activity and 2 to 3 days per week of resistance training. Then once they actually get to altitude, after they hit 3,000 meters, so we're really talking about the high altitude here, they should not ascend more than about 300 meters or 1,000 feet per day, and limit their activity. The first few days, take it easy, and don't plan to go straight to altitude and do some sort of major marathon-type activity. They also want to be careful about their fluids. When you go to altitude, the changes that occur result in a lower plasma volume. So you want to maintain hydration and also avoid fluids that will dehydrate, which includes anything with caffeine, sports drinks, energy drinks, or alcohol. And certainly if they are running into symptoms, that probably means they've ascended too rapidly, and so they probably should take it easy and wait before ascending further. For the cardiovascular symptomatic patients, we tell our patients with coronary disease and heart failure some of the points that we mentioned before in terms of generally in all of these conditions, whether it be coronary disease, heart failure, or patients with arrhythmias, their symptoms tend to come on a little bit earlier and at a lower degree of activity than at sea level. So we kind of talk to them about that. Certainly if they have had a recent episode of hospitalization for their condition, we want to hold off their travel for a little while until they're more stable. And certainly, if any questions, they should be tested. Now, I did want to mention there was a paper that came out after our paper from the British Society in the journal Heart, and they've actually made some specific recommendations in terms of time for some of the patients who have had some unstable conditions. So I just would like to mention that for our listeners, because these patients they will be seeing and may be asking about this. In terms of someone who has had a coronary stent, the British Society recommends that in patients who have just had a coronary stent, if they are doing well and uncomplicated case, discharged home, the British Society recommends that after 2 days, these individuals can fly. However, if their course has been a little bit more complicated and or they've had some other symptoms, they and we recommend waiting a couple of weeks prior to ascending to altitude. For patients who have had surgery, coronary artery bypass grafting, their recommendations are to wait about 10 days to 3 weeks after bypass surgery. And the main reason for this difference is that, as our listeners are aware, during coronary surgery, there's a lot of gas that is introduced when they're on the bypass pump, and this gas can actually sit in the body for up to 10 days before it diffuses back. And so the difference is mainly related to that fact. We have to wait a little bit longer, and also these patients, their chest is going to be a little bit more tender, and they will probably feel better waiting for a little bit longer.
That sounds like good advice for our patients after a bypass.
Definitely, Mike. And then finally, a couple of points. We get asked about patients with pacemakers and ICDs. The safety of pacemakers actually has not been well evaluated, other than there have been a couple of case reports saying that there was no issues with pacemakers. We don't know the answer to that question. Regarding ICDs, the British guideline actually does recommend that in an uncomplicated case, patients can fly after a couple of days after they've had their ICD. So based on everything that I've come across, I think it would be reasonable for a patient with a pacemaker or an ICD to be able to travel to altitude in an uncomplicated case after a couple of days. But certainly, like with any major event that happens with a patient with an ICD or a pacemaker, when they get back, to have it reinterrogated to make sure that the settings and the thresholds are all okay. And then finally, Mike, blood pressure is an issue that patients ask us about. The good news for blood pressure patients is that no worries. And the reason for that is that, interestingly, they do get a change in their parasympathetic-sympathetic nervous system. So there is an initial increase in the cardiac output. And so one would think, well, blood pressure is the product of cardiac output and total peripheral resistance. If we increase cardiac output, however, they get a systemic vasodilatation, so their total peripheral resistance decreases, so they offset each other. So the net effect on blood pressure is that the blood pressure actually remains unchanged.
Well, Dr. Higgins, I want to take this time to thank you very much for sharing this fascinating information with our audience today.
Thanks again for having me, Mike, and I appreciate their interest.